Dr. Kenneth Hartwell had been working the emergency room at Metropolitan General Hospital for 12 years, long enough to develop what he considered a refined ability to distinguish between genuine medical emergencies and what he privately called drug-seeking behavior. At 47, he'd seen enough patients claiming severe pain to recognize the patterns, or so he believed. The Friday night shift was in full swing, the usual parade of minor injuries, anxiety attacks mistaken for heart problems, and people who'd waited too long to address manageable conditions. Kenneth moved through patients with efficient detachment, his beside manner professional but distant. At 11:47 p.m., a new patient was brought into examination room 4. The chart read, Dr. Maya Patel, 41, presenting with severe abdominal pain, nausea, fever 101.3 degrees Fahrenheit. Kenneth barely glanced at the doctor prefix. Plenty of people with doctoral degrees in fields unrelated to medicine use the title. Didn't mean they understood medical issues any better than anyone else. He entered the examination room to find a woman curled on the bed, clearly in significant pain. She was Indian American, dressed in casual clothes, jeans and a sweatshirt, her face pale and sweating. No makeup, no jewelry except a simple wedding band. She looked exhausted. Dr. Patel? Kenneth read from the chart without really looking at her. What brings you in tonight? Severe abdominal pain. Maya managed through gritted teeth. Lower right quadrant. Started about 6 hours ago. Progressively worse. Fever, nausea, can't keep anything down. Kenneth's internal assessment was already forming. The precise medical terminology, the detailed symptom description, classic signs of someone who'd researched their condition online and was now performing for pain medication. On a scale of 1 to 10, how would you rate your pain? 8, maybe 9. Another red flag in Kenneth's mind. Everyone said 8 or 9. If he had $1 for every 8 or 9 that turned out to be gas or muscle strain, he could retire early. Have you taken anything for the pain? Ibuprofen. Didn't help. Any history of abdominal issues? No. This came on suddenly this afternoon. Kenneth performed a cursory physical examination, pressing on Maya's abdomen, checking her vital signs. She flinched when he pressed on the lower right quadrant, crying out in pain. That hurts, she gasped. Please. I need to press to evaluate, Kenneth said dismissively. Her reaction seemed excessive to him. Performative. He stepped back, making notes on his tablet. Your vitals are relatively stable. Low-grade fever, slightly elevated heart rate, consistent with anxiety. The pain you're describing could be anything from gas to muscle strain to stress-related symptoms. Maya stared at him in disbelief. This isn't gas. I know what gas feels like. This is severe, acute pain that's getting worse. Combined with fever and my symptoms, this presents like appendicitis. Kenneth felt his assessment solidify. Self-diagnosis from internet research. Exactly what he'd suspected. Dr. Patel, I appreciate that you're concerned, but I'm the medical doctor here. I've examined hundreds of cases of abdominal pain. The vast majority are not emergencies. You're presenting with nonspecific symptoms that could have multiple explanations. Then run tests, Maya said, her voice strained. CBC, CT scan. If it's appendicitis, it needs immediate intervention. The demanding tone sealed it for Kenneth. This was definitely drug-seeking behavior masked as medical knowledge. Probably thought using medical terminology would make her more credible. I don't order expensive tests for every patient who comes in with a stomachache. That's not responsible medicine. This isn't a stomachache. I'm going to prescribe you something for the pain and nausea. Go home, rest, follow up with your primary care physician if symptoms persist. If it gets significantly worse, come back. You're not listening to me, Maya said, trying to sit up despite the pain. I'm telling you this is serious. The pain is localized, acute. I have rebound tenderness. Ma'am, please don't try to diagnose yourself. You're experiencing pain, yes, but nothing in my examination suggests an emergency. You're stable enough to go home. I need imaging. I need blood work. What you need, Kenneth interrupted, his patience exhausted, is to go home and stop trying to tell me how to do my job. I've been practicing emergency medicine for 12 years. I know the difference between a genuine emergency and someone who's anxious about normal body functions." Maya's face flushed. Whether from fever or anger, Kenneth didn't care. "You're making assumptions about me. I'm making a medical assessment based on my examination and experience. Now, I have other patients who need attention. The nurse will bring your discharge papers and prescriptions." He left before Maya could respond, already moving on to the next patient. Room 5 had a possible broken ankle that would actually require x-rays and orthopedic consultation. A real medical issue, not someone with a stomachache demanding CT scans. Maya lay in the examination room, pain radiating through her abdomen, fever climbing, feeling dismissed and humiliated. She pulled out her phone with shaking hands and called her husband. "David? I'm at Metro General. The doctor won't run tests. He thinks I'm drug-seeking." David's voice came through concerned and tight with barely controlled anger. "What? Did you tell him who you are?" "No. I didn't want special treatment. I wanted medical treatment, but he's sending me home with pain medication and telling me to follow up with my primary care." "Maya, you need to tell him. You're not just any patient. I shouldn't have to be someone important to receive proper medical care." She was right, and David knew it. But she was also in serious pain, possibly with a life-threatening condition, being dismissed by an arrogant doctor who'd decided she wasn't worth his time. "I'm coming to get you," David said. "We're going to a different hospital." 20 minutes later, David arrived to find Maya barely able to walk to the car. Her pain had intensified, her fever had climbed to 102.1 degrees Fahrenheit, and she was visibly deteriorating. "We're going to University Hospital," David said, helping her into the passenger seat. "They have a better ER. And Maya, this time tell them who you are, please." They arrived at University Hospital's ER at 1:15 a.m. The triage nurse took one look at Maya's condition and immediately brought her back. The attending physician, Dr. Sarah Chen, listened carefully to Maya's symptoms, performed a thorough examination, and immediately ordered blood work and imaging. "Your presentation is highly concerning for acute appendicitis," Dr. Chen said. "We need to rule that out immediately." "Thank you," Maya whispered. "The doctor at Metro General thought I was drug-seeking." Dr. Chen's expression darkened. "What doctor?" "Kenneth Hartwell." "I know Kenneth, and I'm sorry you experienced that." She squeezed Maya's hand gently. "We're going to take care of you properly." The CT scan confirmed what Maya had known all along: acute appendicitis with early signs of perforation. She was rushed into emergency surgery at 2:30 a.m. The surgeon who operated on her, Dr. James Mitchell, came to speak with David in the waiting room afterward. "Your wife is stable. The surgery went well, but I need you to understand, we were very close to a rupture. Another few hours and we would have been looking at peritonitis, sepsis, potentially fatal complications." David's face went pale. The doctor at Metro General sent her home, told her it was gas or anxiety. Dr. Mitchell's jaw tightened. "That's medical negligence. Your wife presented with textbook symptoms of acute appendicitis. Any competent emergency physician should have recognized that and ordered appropriate testing." "She's Dr. Maya Patel," David said quietly. "She works for the CDC. She's the deputy director of the National Center for Emerging and Zoonotic Infectious Diseases." Dr. Mitchell sat down heavily. He dismissed a CDC deputy director presenting with acute appendicitis. He dismissed a woman in severe pain. "The fact that she's a senior CDC official shouldn't matter, but I think you understand why I'm mentioning it now. Because there are going to be consequences. There need to be consequences. Not because of who Maya is, but because of what he did. How many other patients has he dismissed? How many other people has he sent home with potentially life-threatening conditions because he decided they were drug-seeking or anxious?" Dr. Mitchell nodded slowly. "I'll be filing a formal incident report. This is exactly the kind of negligence that kills people." Maya remained in the hospital for 3 days, recovering from surgery. During that time, David filed a formal complaint with Metropolitan General's Patient Advocate Office, detailing the dismissive treatment, the refusal to order appropriate tests, and the near-fatal consequences. The complaint went to the hospital's chief medical officer, Dr. Robert Singh, who reviewed Maya's Metro General records and her subsequent surgery at University Hospital with growing alarm. Dr. Kenneth Hartwell was called into Dr. Singh's office 5 days after Maya's ER visit. "Dr. Hartwell, I need to discuss a patient complaint. Maya Patel presented 11 days ago with severe abdominal pain." Kenneth barely remembered her. The drug seeker? She was fine. Stable vitals, probably anxiety. She had acute appendicitis with early perforation. She required emergency surgery hours after you sent her home. The surgeon's report indicates she was close to sepsis. The words hit Kenneth like a physical blow. "What?" Dr. Singh slid the surgical report across his desk. "This is what you missed. Textbook presentation of appendicitis. Right lower quadrant pain, fever, rebound tenderness, nausea. She even told you she suspected appendicitis. You dismissed her without running a single diagnostic test." Kenneth read through the report, his face draining of color. She seemed like she was drug-seeking. The way she described her symptoms, it seemed performative. She described her symptoms accurately because she's a medical professional. Dr. Maya Patel is the Deputy Director of the National Center for Emerging and Zoonotic Infectious Diseases at the CDC. The room seemed to tilt. "She's... what?" "She's one of the country's leading epidemiologists. She has an MD and a PhD in infectious diseases. She spent years working in emergency response for disease outbreaks. She knows exactly what medical symptoms look and feel like. She didn't tell me. She shouldn't have had to." Her credentials are irrelevant to whether she deserved proper medical care. But the fact that you dismissed someone with extensive medical training presenting with clear symptoms of a surgical emergency suggests a serious problem with your clinical judgment. Kenneth felt sick. "If I'd known who she was—" "That's the problem," Dr. Singh interrupted. "You should have provided the same standard of care regardless of who she was. But let's be honest about what actually happened here. You saw a woman of color in casual clothes complaining of pain, and you decided she was drug-seeking without proper evaluation. That's not... Dr. Hartwell, I've reviewed your patient files from the past year. You have a pattern. Patients of color, particularly women of color, are significantly more likely to have their pain dismissed by you, significantly less likely to receive appropriate diagnostic testing, and significantly more likely to be labeled as drug-seeking in your notes." Dr. Singh pulled up data on his computer. "In the past 12 months, you've noted possible drug-seeking behavior in the charts of 47 patients. 41 of them were people of color. 34 were women. Only 6 were white men." Kenneth stared at the numbers, unable to process what they revealed about his own biases. "Meanwhile," Dr. Singh continued, "you ordered CT scans and comprehensive blood work for 73 patients presenting with abdominal pain. 68 were white. Only 5 were people of color. The disparity in care you provide based on patient race and gender is statistically significant and medically indefensible. I never consciously... Bias doesn't have to be conscious to be harmful. And in this case, your bias nearly killed a patient. If Dr. Patel hadn't had the resources to go to another hospital, if her husband hadn't been able to advocate for her, if she'd followed your instructions and gone home to rest, she would likely have died of septic shock." Kenneth's hands were shaking. "What happens now?" "You're suspended pending a full investigation. The hospital's equity committee will review all of your cases from the past 3 years. If the pattern of discriminatory care continues throughout your history here, you'll be terminated. Dr. Singh, please. You nearly killed a CDC official, Dr. Hartwell. And not because you lack medical knowledge, but because you let your biases override your clinical judgment. That's not a mistake. That's a pattern of negligent, discriminatory care that has no place in this hospital." The story spread quickly through medical circles. A prominent CDC official nearly died because an ER doctor dismissed her symptoms as drug-seeking. The incident sparked conversations about bias in pain management, about how women and people of color are routinely undertreated for pain, about how implicit bias kills patients. Maya, recovering at home, received calls from colleagues, friends, and strangers sharing their own stories of dismissed symptoms, misdiagnoses rooted in bias, and medical professionals who saw race or gender before they saw patients. A reporter from a medical journal asked to interview her about the experience. "What I experienced isn't unique," Maya told the reporter. "Studies show that Black patients are 40% less likely to receive pain medication than white patients with identical conditions. Women's pain is routinely dismissed as emotional or exaggerated. I'm fortunate. I had the medical knowledge to know something was seriously wrong, the resources to get a second opinion, and ultimately the credentials that forced people to take my treatment seriously. But most patients don't have those advantages. They trust their doctors, and when those doctors let bias override medical judgment, people die." The article went viral in medical communities. Medical schools started using Maya's case in their curriculum on bias in healthcare. Hospital systems implemented new protocols for pain assessment and diagnostic testing to reduce disparities. Metropolitan General Hospital conducted the promised investigation of Kenneth Hartwell's patient records. The findings were damning. Over 3 years, he'd provided consistently lower standards of care to patients of color, particularly women of color. His dismissal rates, his diagnostic testing orders, his pain medication prescriptions all showed clear patterns of bias. He was terminated. His medical license was suspended pending review by the state medical board. 6 months after the incident, Maya was invited to speak at a medical conference about bias in emergency medicine. "I'm standing here today because I survived medical negligence rooted in bias," she began. "I presented with textbook symptoms of a surgical emergency. I was examined by a doctor who decided I was drug-seeking before he'd even finished looking at my chart. He sent me home without diagnostic testing, without blood work, without imaging, based purely on his assumption that a woman of color in casual clothes complaining of severe pain must be lying." She paused, letting her words settle over the hundreds of physicians in the audience. "I'm fortunate. I had the resources to get a second opinion. I had a husband who could advocate for me when I was too sick to advocate for myself. I had credentials that eventually forced people to take me seriously, but I shouldn't have needed any of that. I should have received appropriate medical care because I was a patient presenting with concerning symptoms. How many patients don't have what I had? How many people experience the same dismissive treatment and don't have the resources to fight it? How many die because doctors let their biases override their medical training?" The silence in the room was profound. The doctor who treated me isn't unique. He's part of a systemic problem in healthcare where bias, racial bias, gender bias, socioeconomic bias, determines who receives proper care and who gets dismissed. Studies consistently show that patients of color receive less pain medication, fewer diagnostic tests, less thorough examinations than white patients with identical symptoms. This isn't about individual bad doctors. It's about a system that allows bias to flourish, that doesn't train physicians to recognize and combat their own prejudices, that doesn't hold doctors accountable when their bias leads to negligent care. I'm calling on every physician in this room to examine their own practice. Look at your diagnostic testing rates by patient race. Look at your pain medication prescriptions by patient gender. Look at how much time you spend with patients who look like you versus patients who don't. The data will probably be uncomfortable, but discomfort is better than negligence, and accountability is better than another preventable death. The standing ovation was immediate and sustained. After the conference, Kenneth Hartwell, who'd been in the audience trying to understand what he'd done and how to do better, approached Maya. "Dr. Patel, I owe you an apology that I can never adequately express." Maya looked at him, this man whose bias had nearly killed her, who'd dismissed her pain and her medical expertise because he'd decided who she was based on her appearance. "Why are you here?" she asked. "Because I'm trying to understand how I became someone who let patients suffer because of my biases. I'm in therapy. I'm taking courses on implicit bias. I'm reading everything I can about healthcare disparities, and I'm here because I needed to hear this, even though it's painful. It should be painful. You nearly killed me, and you've probably harmed dozens of other patients over the years with the same biased assumptions. I know, and I'm trying to understand how to do better, how to be better. Maya studied him. Do you understand that you didn't dismiss me because I was faking symptoms? You dismissed me because you saw a brown woman and decided I wasn't credible, that my pain wasn't real, that I was probably seeking drugs. Yes, Kenneth whispered. I see that now. But at the time, I genuinely believed I was making good medical judgments based on my experience. That's what makes bias so dangerous. It feels like clinical judgment. It feels like pattern recognition, but it's actually prejudice masquerading as professional expertise. How do I fix it? How do I make sure I never do this again? You can't fix what you did to me. My appendix was removed. I spent 3 days in the hospital. I faced potential sepsis. That happened. But you can commit to treating every patient with the same thorough care you'd want for yourself. You can recognize when your instincts about a patient are actually just bias. And you can advocate for systemic changes that reduce disparities in healthcare. Will you accept my apology? Maya considered. I accept that you're genuinely sorry. I accept that you're trying to do better, but forgiveness isn't something I owe you. What I need from you is different care for future patients. That's how you make amends, not by apologizing to me, but by never letting bias override your medical judgment again. Kenneth nodded, his eyes wet. I understand. And thank you for even speaking with me. A year after the incident, Metropolitan General implemented comprehensive reforms, mandatory implicit bias training for all staff, protocols ensuring equitable diagnostic testing regardless of patient demographics, regular audits of care disparities, and a patient advocate specifically focused on addressing bias complaints. Maya returned to her work at the CDC, but she'd also become an advocate for healthcare equity, speaking at conferences, consulting with hospital systems, pushing for policy changes that would protect other patients from what she'd experienced. 3 years after nearly dying from dismissed appendicitis, Maya received an award from the National Medical Association for her advocacy work in addressing bias in healthcare. In her acceptance speech, she said, I didn't set out to become an advocate for healthcare equity. I became one because a doctor's bias nearly cost me my life. But I'm fortunate. I survived. I had resources. I could fight back. This award isn't really for me. It's for every patient who couldn't fight back. Every person whose pain was dismissed, whose symptoms were ignored, whose life was devalued because a healthcare provider let bias override medical judgment. We've made progress. Hospitals are implementing bias training. Medical schools are teaching about disparities. Doctors are examining their own practices. But we have so much further to go, because every day, patients of color, women, LGBTQ individuals, disabled people, and others face bias in healthcare that leads to poorer outcomes, inadequate treatment, and preventable deaths. My message to healthcare providers is simple. Examine your biases. Look at your data. Be willing to confront uncomfortable truths about disparate care, and commit to treating every patient with the same thoroughness you'd want for yourself or your family. Because the patient you dismiss today might be a CDC official, or they might be a grocery store clerk, or a teacher, or unemployed. And it shouldn't matter. Every person deserves competent, unbiased medical care. That's not a special request. It's the bare minimum of what medicine should be. 5 years after the incident, Kenneth Hartwell was working as a consultant helping hospitals identify and address bias in their emergency departments. His medical license had been reinstated after extensive training and supervision, but he'd chosen not to return to clinical practice. I don't trust myself in an emergency setting anymore, he told a colleague. I spent 12 years thinking I was a good doctor, never realizing that my bias was harming patients. Now I know better, but I also know that bias operates unconsciously. I can't be confident that I wouldn't fall back into old patterns under the pressure of a busy ER. So instead, I help other doctors see what I couldn't see. I review patient care data, identify disparities, facilitate difficult conversations about bias. It's penance, I suppose, but more than that, it's trying to prevent what happened to Dr. Patel from happening to anyone else. The colleague asked, "Do you think about her case often?" "Every day. Not just what I did to her, but what I probably did to dozens of other patients I'll never know about. How many people did I send home with serious conditions because I decided they were drug-seeking? How many missed diagnoses? How many complications? How much unnecessary suffering? All because I let my biases override my medical training. That's a heavy burden. It should be. What I did was inexcusable, and the fact that it's common, that bias in healthcare is endemic rather than exceptional, that should horrify all of us. A decade after nearly dying from dismissed appendicitis, Maya Patel was appointed as the director of the CDC. In her first major address, she spoke about health equity and the systemic barriers that prevent marginalized communities from accessing quality health care. 10 years ago, I presented to an emergency room with acute appendicitis. The doctor dismissed my symptoms without proper examination or diagnostic testing. He sent me home to die because his bias told him I wasn't credible. I survived because I had resources most patients don't have: access to a second hospital, a husband who could advocate for me, and eventually credentials that forced people to take my condition seriously. But I shouldn't have needed any of that. Every patient deserves to be believed. Every patient deserves thorough examination and appropriate testing. Every patient deserves care that's based on medical evidence rather than provider bias. As CDC Director, I'm committing this agency to addressing health disparities at every level. We'll study bias in healthcare delivery. We'll develop training programs. We'll establish standards for equitable care. And we'll hold healthcare systems accountable when they fail to provide equal treatment to all patients. Because no one should have to nearly die to be taken seriously. No one should need a medical degree or government position to receive competent health care. And no one should suffer because a provider's bias was stronger than their commitment to medical excellence. The audience, healthcare providers, public health officials, policymakers, gave her a standing ovation. Because sometimes the patient you dismiss isn't just a patient. Sometimes there's someone with the power to change the entire system that allowed that dismissal to happen. And sometimes, just sometimes, that person uses that power not for revenge, but for reform. Not to punish one negligent doctor, but to prevent future patients from suffering the same negligent care. If this story resonated with you, remember, bias in healthcare kills. Women's pain is routinely dismissed. Patients of color receive inadequate treatment. And the clinical judgment that providers trust is often just prejudice wearing a white coat. Share this with healthcare providers, medical students, patients, and advocates. Remind them that every person deserves thorough medical care, not because they might be important, but because competent, unbiased treatment should be universal. Subscribe to Real Justice Stories for more tales of bias confronted, systems reformed, and the power of using authority to create change rather than just seeking personal vindication. Thank you for watching. Remember, the patient you dismiss today might be a CDC director, but that shouldn't matter. Treat everyone like their life depends on your care, because it does.